Cervical cancer screening, prevention through early detection. Cervical cancer screening identifies precancerous and cancerous changes in the cervix before they progress to invasive disease. Modern screening methods combined with vaccination have dramatically reduced cervical cancer incidence and mortality. Understanding cervical cancer screening. Cervical cancer screening represents one of the most successful public health interventions in oncology. This systematic approach to identifying disease in asymptomatic individuals has fundamentally transformed outcomes for women at risk. Rather than waiting for symptoms to develop, screening detects changes occurring within cervical tissue before they become dangerous. The methodology depends on recognizing viral markers and cellular abnormalities that indicate increased cancer risk. By implementing regular screening programs, healthcare systems worldwide have achieved substantial reductions in both incidence rates and mortality associated with this malignancy. The role of human papillomavirus in cervical disease. Human papillomavirus, HPV, infection serves as the primary driver of cervical cancer development. This common sexually transmitted pathogen can establish persistent infections in cervical epithelial cells, particularly high-risk strains including HPV-16 and HPV-18. Not all women exposed to HPV develop cancer, as most infections resolve spontaneously through immune clearance. However, certain individuals experience chronic infection that leads to progressive cellular changes. Understanding this disease mechanism has revolutionized screening approaches, allowing clinicians to focus detection efforts on women carrying the most concerning viral strains. This knowledge also informed the development of vaccines that prevent initial HPV acquisition, creating opportunities for primary prevention before exposure occurs. Contemporary screening methodologies. The evolution of screening technology has progressively enhanced detection capabilities while reducing unnecessary procedures. Traditional cytology, commonly known as the Pap test, revolutionized cervical cancer prevention when introduced decades ago. This examination involves collecting cells from the transformation zone where most cancers originate, then evaluating them microscopically for dysplastic changes. More recent approaches prioritize HPV testing as a primary screening modality, recognizing that viral presence more accurately predicts which individuals face genuine cancer risk. Liquid-based collection methods have standardized specimen handling and improved diagnostic accuracy compared to conventional preparation techniques. These methodologic advances allow clinicians to stratify women into risk categories more precisely, ensuring that those requiring intensive follow-up receive appropriate attention while sparing low-risk individuals from excessive intervention. Key points: cytology-based testing examines cervical cells under microscopy to identify morphologic abnormalities characteristic of dysplasia or malignancy. HPV DNA detection directly identifies viral genetic material in cervical specimens, determining whether high-risk strains are present. Reflex testing protocols use initial screening results to determine whether additional evaluation is necessary. Co-testing combines cytologic and HPV assessment in a single visit to maximize sensitivity for detecting significant lesions. Screening guidelines and recommended intervals. Professional organizations have established evidence-based recommendations that balance cancer detection with minimizing unnecessary evaluation. Most guidelines recommend beginning screening at age 21, acknowledging that cervical cancer rarely occurs in adolescence and that screening younger women produces substantial false positive results leading to overtreatment. Screening intervals depend on the specific methodology employed and prior results. Women with consistently negative cytology and negative HPV testing may extend screening intervals to 3 to 5 years, whereas those with abnormal results require closer surveillance and often colposcopic evaluation. Screening typically continues until age 65 to 70 in women with adequate prior negative results, as incidence and mortality decrease substantially in older age groups and screening becomes less cost-effective. Guidelines emphasize individualization based on personal risk factors, screening history, and clinical circumstances. Abnormal results and clinical follow-up. When screening identifies abnormal findings, subsequent evaluation determines the significance of detected changes and guides appropriate management. Cervical interepithelial neoplasia, CIN, represents a continuum of dysplastic changes ranging from mild alterations to severe lesions with substantial malignant potential. Most women with mild dysplasia experience spontaneous regression without intervention, as their immune systems effectively clear the underlying HPV infection. Moderate and severe dysplasia require more aggressive management through excisional procedures that remove abnormal tissue while preserving cervical function. Colposcopy, an office-based procedure using magnified visualization and tissue sampling, provides detailed assessment of abnormal areas and directs biopsy toward the most concerning regions. This systematic approach ensures that treatment intensity matches lesion severity, avoiding both under-recognition of significant disease and unnecessary procedures for self-limited conditions. Treatment of precancerous lesions. Removing precancerous lesions before they progress to invasive cancer represents the fundamental prevention strategy underlying screening programs. These procedures achieve excellent success rates, typically preventing cancer development in over 90% of treated women. Excisional techniques that remove tissue margins allow pathologists to assess whether dysplasia has been completely eliminated and whether any unexpected findings are present. Following treatment, enhanced surveillance becomes necessary since HPV persistence increases recurrence risk. Most women successfully treated for precancerous disease return to routine screening after appropriate post-treatment intervals, with the vast majority remaining cancer-free. The remarkable success of this approach demonstrates how screening coupled with timely treatment converts what was historically a lethal malignancy into a largely preventable disease. Key points: loop electrosurgical excision procedures, LEEP, remove abnormal tissue while allowing histologic examination of margins and excised lesion. Cold knife conization provides precise excision, particularly useful when margin assessment is critical or when endocervical involvement is suspected. Laser conization offers alternative excisional technique with potentially less cervical trauma in selected cases. Hysterectomy may be considered in women with recurrent disease or concurrent gynecologic indications for uterine removal. Integration of vaccination with screening. Prophylactic HPV vaccines have created unprecedented opportunities to prevent cervical cancer through primary prevention. These vaccines target specific viral types responsible for the majority of cervical malignancies, stimulating immune responses that prevent initial infection. Vaccination programs implemented in adolescence before sexual activity begins offer the greatest cancer prevention benefits. However, vaccination has implications for screening strategies, as women vaccinated against HPV-16 and HPV-18 carry substantially lower cancer risk. Some experts propose modified screening approaches for fully vaccinated cohorts, potentially including delayed initiation or extended intervals. The integration of vaccination with established screening programs creates comprehensive prevention strategies addressing both primary prevention through immunization and secondary prevention through screening. As vaccination coverage expands globally and vaccinated populations age into screening years, the epidemiology of cervical cancer will continue to shift toward even lower incidence rates. Disparities in screening access and outcomes. Despite the proven effectiveness of screening, significant disparities persist in access and outcomes across different populations. Socioeconomic factors, geographic location, insurance status, and cultural beliefs create barriers that prevent many women from receiving regular screening. Underscreened populations experience disproportionately higher cervical cancer incidence and mortality, often presenting with advanced stage disease requiring more aggressive treatment. Healthcare systems must implement targeted interventions to overcome these barriers, including community education, accessible screening locations, and culturally sensitive approaches. Improving screening equity requires addressing underlying social determinants while expanding capacity in underserved regions. Public health initiatives emphasizing universal screening availability represent essential complements to clinical practice, ensuring that screening benefits reach all women regardless of social circumstances. Special populations and screening considerations. Certain populations require modified screening approaches or enhanced vigilance. Immunocompromised women, including those living with HIV or following organ transplantation, experience accelerated HPV-related disease progression and warrant more frequent screening intervals. Women with prior abnormal results or treatment for dysplasia need continued surveillance beyond standard protocols, as their demonstrated HPV susceptibility indicates elevated recurrence risk. Those with diethylstilbestrol, DES, exposure in utero require specialized evaluation including examination of the vagina and vulva, as adenosis and clear cell adenocarcinoma represent additional cancer risks. Transgender men who retain cervical tissue benefit from screening just as cisgender women do, though they face particular barriers to care that healthcare systems must actively address. Pregnancy does not contraindicate screening, though colposcopy and biopsies generally defer unless high-grade lesions are suspected. Understanding these special circumstances ensures comprehensive cancer prevention across diverse patient populations. Future directions in cervical cancer prevention. Emerging technologies promise to further improve screening accuracy and efficiency. Artificial intelligence algorithms applied to cervical cytology may enhance sensitivity and consistency in identifying abnormalities, reducing observer variability. Molecular testing approaches beyond HPV detection may identify additional biomarkers predicting progression risk, allowing finer risk stratification. Self-sampling options that allow women to collect specimens independently could improve access in settings with limited clinical resources or cultural barriers to gynecologic examination. Expanding HPV vaccination programs globally, particularly in low-resource settings experiencing the highest cervical cancer burden, offers tremendous potential for primary prevention. Continued research into optimal screening intervals and methodologies will refine protocols as evidence accumulates. These advances collectively position cervical cancer screening at the intersection of prevention, early detection, and precision medicine, offering prospects for continued mortality reduction worldwide. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.